yourself first and foremost, your affiliation, your title, who you're working with. So with Gardner Webb, Jamie Camp, physician assistant student with Dr. Smith today. And so get the patient's name, date of birth first and foremost.
Isabella Kim, 6/22/96.
And after you've done that, you can proceed to wash your hands, or you can say, what brings you in today?
For a physical exam.
Good, so physical exam. So if it's okay, I'm going to go ahead and wash my hands. And so typically I carry on casual conversation while washing my hands. Ask her how her weekend is, game plans this weekend, whatever. And then make sure the lighting's okay, room's okay. I would make sure the patient's comfortable before I get started. I would demonstrate professionalism at all times, try to protect the patient's modesty, and make sure first and foremost too that the patient has emptied their bladder. Do you need to empty your bladder before we start the exam? So she's okay. So with that being said, we want to make sure the table is flat. Okay, so the patient's going to be in the supine position, so I'll go ahead and have Isabella lay back. One of the things that we always want to do, is my time up, is lay this back. There's nothing worse than a student that has the patient, come up a little bit, Isabella, like this the whole exam. They're just sitting there. And I'm not going to correct you. All right, but if I ever record you on OSCE, I'm going to put a comment that says, my back is killing me. With the exclamation point. You know what that means, okay? So always do this. It should be commonplace, okay? Are you comfortable? Lying flat? Okay. So, first of all, what we want to do is make sure we have access to the abdomen before we begin our inspection. So here I have pretty good clearance up here. If I need her to raise any, I can get her to help me with that. Here is a good example of being in the clinic and having that lower quadrant covered up a little bit, okay? I really can't get good access to see what I need to see because this dividing line here is where her upper and lower quadrants meet. So I'd ask Isabella, is there any way that you can lower just a little bit, 2 or 3 inches, to where you feel comfortable, okay, down. Okay, so that's good. So now I've got 2 or 3 inches here, and I've got some access to that lower area. She feels comfortable, I hope. I feel comfortable assessing that. All right, at this point, Ashley is going to begin reading. I think the first thing I do is inspect the abdomen.
Inspect the abdomen for contour and symmetry.
So we're looking at contour. So if we looked at Isabella's abdomen and we took a look at it, I would say she's pretty flat abdomen, okay? Maybe have just a little bit of concavity to it, but for the most part, she's got a flat abdomen. And so as I inspect it, looking for symmetry that both sides, if I were to cut it in the middle or cut it this way, both look right, but really right and left. And so I see symmetry. As I look, I'm looking for any type of striae, any type of masses, rashes, any type of obvious lesions. She's got a few little freckles here, but nothing major. Okay, and so when I'm looking at her abdomen, I'm looking at that. I can look for pulsations. If I do that, really what I need to do is have a pen light, and I can kind of get down with tangential lighting, and I can look to see if I can see her pulsations of her abdomen. And she's kind of small, so I actually technically can see them a little bit when she fully expires. I don't see any peristalsis movement going on right now. But like I said, sometimes in thin patients you can visualize those particular things. So next I would, and tell me if I leave something out, would inspect her abdomen around the umbilical area. And I'm just looking to make sure there's no redness. She has what we would call an innie. It doesn't matter if it's an innie or outie. You want to look. If it's an outie, you want to definitely make sure it's not out and protruding and has a hernia. With innies, you can tell a little bit better that there's not a hernia there, but it always can be periumbilical, okay? So what I would do is access with some intra-abdominal pressure through a valsalva maneuver, ask her to lift her head off the bed, tighten her abdomen, lift her shoulders up just a little bit, because that really puts the pressure there. And not only would I look for epigastric, incisional if she had had surgeries, but I also look for umbilical hernia and then temper the rest, okay? So after I've done that particular part of the inspection,
Auscultation.
we're ready to move on to listening, okay? And so I had your stethoscope somewhere,